So yeah, in today's class we'll be starting with intersusception. In the previous classes we have discussed about small bowel obstruction and some conditions like paralytic ileus also. Okay, so today we are starting with intersusception. What does it mean? It means telescoping of one segment of bowel into another. Basically, if this is a bowel segment and this is another bowel segment, one bowel segment will enter into another bowel segment. This is called as telescoping. So this is most commonly seen in age group of 4 to 10 months of age, and this is called as weaning age. Weaning age andreno, it is the transition period of a child from breastfeeding to complementary foods. So from birth to 6 months it is exclusively breastfed. Okay, from after 6 months onwards complementary foods are started. So when this complementary food is started in the baby, there is an increased risk of one bowel entering into the another bowel because peristalsis is new now. So because of that reason, there is increased risk of intersusception in 4 to 10 months of baby. Okay, ಯಾವ ರೀಜನ್ ಅಲ್ಲಿ ಆಗುತ್ತೆ ಅಂದರೆ ಇಲಿಯಮ್ ಗೆಟಿಂಗ್ ಇಂಟು ಕೋಲಾನ್. ಓಕೆ, ಸೊ ದಟ್ ಈಸ್ ಇಲಿಯೋಕೋಲಿಕ್ intersusception. So this is most common in case of children, and in case of adults colocolic ಅಂದರೆ one part of the colon itself getting into another part of the colon. Okay, ಸೊ ವಾಟ್ ಆರ್ ದ ಪಾರ್ಟ್ಸ್ ಆಫ್ ಇಂಟರ್ಸೆಸೆಪ್ಷನ್? ಇವಾಗ ಇಂಟರ್ಸೆಸೆಪ್ಷನ್ನಲ್ಲಿ ನಾನು ಹೇಳ್ದಂಗೆ ಒನ್ ಸೆಗ್ಮೆಂಟ್ ಈಸ್ ಗೆಟಿಂಗ್ ಇಂಟು ಅದರ್ ಸೆಗ್ಮೆಂಟ್. ಓಕೆ, ಸೊ ಬೇಸ್ಡ್ ಆನ್ ದಟ್ ವಿ ಆರ್ ಲೇಬಲಿಂಗ್ ದ ಪಾರ್ಟ್ಸ್. ಇಂಟರ್ಸೆಸೆಪ್ಟಮ್ ಅಂದರೆ ವಿಚ್ ಈಸ್ ದ ಇನ್ಕಮಿಂಗ್ ಸೆಗ್ಮೆಂಟ್. We can see here. So this segment is the incoming segment and this is the one receiving segment. So this is called as intersusceptum. This is going inside this. So hingiradu. So this is going inside this. So the one that is incoming segment is called as intersusceptum, and the one receiving, this is called as intersusceptions. Okay, and the narrowest part of this intersusception is called as neck, and the most prone part is apex. Like this is apex and this is the narrowest part and this is called as neck. Okay, middle layer is most prone to gangrene because it is sandwiched between the outer layer, inner layer, and this is the middle layer. This middle layer is more prone for gangrene. So ಇದು ಹೆಂಗಾಗುತ್ತಂದರೆ ಈ ಥರ. ಓಕೆ, ಸೊ ದಿಸ್ ಒನ್ ಸೈಡಿಂದ ಮೇಲಿಂದ ನೋಡ್ತಿದ್ದೀವಿ ಅಂತ ಅಂದ್ಕೊಂಡ್ರೆ ದಿಸ್ ಇಸ್ ಔಟರ್ ಲೇಯರ್, ದಿಸ್ ಇಸ್ ಮಿಡಲ್ ಲೇಯರ್ ಆ್ಯಂಡ್ ದಿಸ್ ಇಸ್ ಇನ್ನರ್ ಲೇಯರ್. ಸೊ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗೋದ್ರ ಜೊತೆಗೆ ದಿಸ್ ಮಿಡಲ್ ಲೇಯರ್ ಇಸ್ ಮೋರ್ ಪ್ರೋನ್ ಫಾರ್ gangrene. Okay, so what are the predisposing factors for intersusception? Why does this happen? This, as I said before, it happens more commonly in weaning child. Okay, that is 4 to 10 month old child, and this is also prone for infection during this age group. Up to 6 months maternal antibodies, up to 9 months probably maternal antibodies will be doing the job of immunity. So as the child grows, there will be diminution in this immunity also, which leads it to more which is more prone for infections like rotavirus diarrhea. Okay, also when we give rotavirus vaccine, it increases the risk of intersusception. So what is if they ask you what is the side effect or what is the what leads to intersusception ಅಂತ ಕೇಳಿದ್ರೆ you can say one cause is rotavirus vaccine. Okay, so because of this weaning child there is Peyer's patch hypertrophy, which is a nothing but a malt, mucosa associated lymphoid tissue ಅಥವಾ ಗಾಲ್ಟ್ ಅಂತ ಕರೆಯೋದು, gut associated lymphoid tissue. This is a lymphoid tissue. This leads to hypertrophy and this increases the risk of intersusception. In just like I said, in children the most common type is ileum getting inside the colon. So ileum getting inside the colon because ileum is a part of small intestine, this is a part of large intestine. Caliber ದೊಡ್ಡದಿದೆ, so it is easy, like small intestine getting into large intestine is easy ಆಯ್ತಾ. So that is why most common type of intersusception in children is ileocolic, and lead point is a point which initiate or lead the intersusception. Most common lead point is Meckel's diverticulum, that is polyps. Meckel's diverticulum greater than polyps. Okay, so yeah, okay, after this other lead points for intersusception can be a lipoma or a lymphoma or a villus adenoma or hematoma or henoxylin purpura or cystic fibrosis. Okay, So most common tumor which is responsible for intussusception in children is lymphoma. Just like I said, Peyer's patch hypertrophy tara, there can be other causes. These all are the leads which basically leads to intussusception. Okay. Most common tumor responsible for intussusception in adults is villous adenoma, whereas in case of children is lymphoma. Okay. So clinical features ಏನಿರುತ್ತೆ in case of intussusception ಅಂತ ಕೇಳಿದ್ರೆ, if at the time of attack, if that intersusception, if one bowel is getting into other bowel now currently, then what will be the symptom? Child will cry a lot because abdominal pain irutte, and it will pull its leg towards abdomen because it will release it will relieve pain when it pulls the leg towards abdomen, because it will be a colicky type of pain. Peristalsis ಎಲ್ಲ ಆಗುತ್ತಲ್ಲ, colicky type of pain ಇರುತ್ತೆ. After that, since it is in the most commonly in the region of ileocolic, so it is bilious. So ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಆಗುತ್ತಲ್ವ, ಇದರಲ್ಲಿ ಇಂಟರ್ಸೆಪ್ಷನ್ ಆಗೋದ್ರಿಂದ ಒಂದು ನೆಕ್ರೋಸಿಸ್ ಆಗ್ಬೋದು, ಅದರ್ ಒನ್ ಇಟ್ ಕ್ಯಾನ್ ಲೀಡ್ ಟು ಅಬ್ಸ್ಟ್ರಕ್ಷನ್. ಸೊ ನೆಕ್ರೋಸಿಸ್ ಆ್ಯಂಡ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್, ದಿಸ್ ಈಸ್ causing pain and this is causing vomiting. Okay, in between the attacks, like peristalsis ಆಗ್ತಿಲ್ಲ ಅಥವಾ whenever the small intestine goes into large intestine, it is called an attack. When it comes back, it is normal. Okay, so in between the attack the patient will be normal. Whenever there is an attack, there will be these symptom manifestations. Okay, after many attacks it keeps on happening, then what will happen? There will be passage of small amount of stools which will be mixed with blood, and this appearance is called as red currant jelly appearance. So clinically the patient will be passing red colored stools. Okay, on examination there will be a sausage shaped mass in the right lumbar region, because ileum is in the right lumbar region. Okay, so ileocolically right lumbar region ಅಲ್ಲಿ ಒಂದು ಮಾಸ್ ಸಿಗುತ್ತೆ, that is sausage shaped. Okay, so empty right iliac fossa can also be seen, and this is known as sign of dance. Okay, ಇವಾಗ ಬೇಸಿಕಲಿ ರೈಟ್ ಇಲಿಯಾಕ್ ಫೋಸಾದಲ್ಲಿ ಏನಿರಬೇಕಿತ್ತು, ರೈಟ್ ಇಲಿಯಾಕ್ ಫೋಸಾದಲ್ಲಿ ಇಲಿಯಮ್ ಇರಬೇಕಿತ್ತು, ಆಮೇಲೆ ಅಲ್ಲಿಂದ ಕೊಲೋನ್ ಕಂಟಿನ್ಯೂ ಆಗಬೇಕಿತ್ತು. ಬಟ್ ileum has got into colon and it has moved to right lumbar region, and now it is right iliac fossa is empty. Okay, because of that reason we will feel the mass in right lumbar region, and right iliac fossa is empty. Okay, what is the investigation? Diagnostic and therapeutic is enema, barium enema, ಅಥವಾ ಏರ್ ಯೂಸ್ ಮಾಡಿ ಎನಿಮಾ ಇದು ಮಾಡ್ತಾರೆ ಮೋರ್ ಕಾಮನ್ಲಿ ರಾದರ್ ದನ್ ಬೇರಿಯಮ್. ಓಕೆ, so what is the treatment now? Air enema. Enema creates pressure by which there will be reduction of bowel back to normal. Basically suction ಕೊಟ್ಟಂಗೆ ಏರ್ ಎನಿಮಾದಲ್ಲಿ, that will pull back the intersuscepted ಅಥವಾ ಯಾವ್ದು ಇನ್ಕಮಿಂಗ್ ಸೆಗ್ಮೆಂಟ್ ಇದೆ ಅದನ್ನು pull back ಮಾಡುತ್ತೆ ಏರ್ ಎನಿಮಾ. ರಿಕರೆನ್ಸ್ ಆದರೆ ಏರ್ ಎನಿಮಾ is again repeated. If recurrence occurs for the third time, then we will have to go for surgery, that is ileocolectomy. That is, whatever the part is involved, that part of the ileum and colon is cut off or removed, and then whatever the remaining part is there, that is anastomosed with transverse colon. Okay, so what are the radiological signs we will see in case of intersusception? If we do plain x-ray, we will be seeing target sign or meniscus sign. Target sign ಅಂದರೆ ಹಿಂಗೆ ಈ ಥರ ಕಾಣಿಸ್ತಿರುತ್ತೆ. ಬೇಸಿಕಲಿ ಕ್ರಾಸ್ ಸೆಕ್ಷನಲ್ಲಿ ತಗೊಂಡಿದ್ದಾರೆ. ದಿಸ್ ಈಸ್ ಇಲಿಯಮ್ and the large and diameter one is colon. ಸೊ ಕಟ್ ಮಾಡಿದಾಗ ಈ ಥರ ಕಾಣಿಸ್ತಿದೆ. ದಿಸ್ ಈಸ್ ಲೈಕ್ ಅ ಬೋ ಶೂಟ್ ಮಾಡೋಕ್ಕೆ ಯೂಸ್ ಮಾಡ್ತಾರಲ್ಲ ಒಂದು ಟಾರ್ಗೆಟ್, ಆ ಥರ ಕಾಣಿಸುತ್ತಲ್ಲ, ದಟ್ಸ್ ವೈ ಇಟ್ ಈಸ್ ಕಾಲ್ಡ್ ಅಸ್ ಟಾರ್ಗೆಟ್ ಸೈನ್. ಓಕೆ, ಸೊ ನೆಕ್ಸ್ಟ್ ಬೇರಿಯಮ್ ಎನಿಮಾ. ಇನ್ ಕೇಸ್ ಆಫ್ ಬೇರಿಯಮ್ ಎನಿಮಾ ಇಟ್ ವಿಲ್ ಬಿ ಲೈಕ್ ಅ ಕಾಯಿಲ್ಡ್ ಸ್ಪ್ರಿಂಗ್ ಸೈನ್ ಆರ್ ಅ ಕ್ಲಾ ಸೈನ್ ಲೈಕ್ ದಿಸ್. One thing is getting into another, so it is appearing like a coiled spring ಅಥವಾ claw. Okay, so coiled spring sign or claw sign in case of barium enema. And if we do ultrasound, again it will appear like a target sign or a pseudo kidney sign, that is on a longitudinal scan. So this was about intersusception. Okay, ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ? ನೆಕ್ಸ್ಟ್ moving on with colonic pseudo obstruction. Okay, so this is characterized by signs and symptoms of colonic obstruction in the absence of mechanical cause of obstruction. Basically like paralytic ileus. Paralytic ileus allೂ ಮೆಕ್ಯಾನಿಕಲ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಇರಲಿಲ್ಲ, aerodynamic obstruction ಇತ್ತಲ್ಲಿ. There was no mechanical obstruction but there was obstruction. Similarly here there is no mechanical obstruction but there is large bowel obstruction. Okay, what are the types of idiopathic colonic andre what are the types of colonic pseudo obstruction andre idiopathic and secondary ಅಂತ. Idiopathic is the reason, we don't know exactly what is the reason, hence it is called as idiopathic colonic pseudo obstruction. Okay, this is also known as Ogilvie's syndrome. So secondary pseudo obstruction alli we know a cause, it can be these may be the causes anta we have a list. Okay, that is retroperitoneal hematoma or uremia or hypothyroidism or dyselectrolytemia or drugs like opiates and antipsychotics or Parkinson's disease or chronic visceral myopathy. Okay, so what is the etiology? Whenever there is a sympathetic overactivity, that will lead to impaired peristalsis and this leads to sluggish bowel sounds, which in turn will cause colonic distension. Basically we all know parasympathetic and sympathetic, two systems are controlling peristalsis. Whenever parasympathetic activity increases, it will lead to increase in peristalsis. So ulta, whenever sympathetic activity increases, it will lead to decrease in peristalsis. So here what is happening? Here sympathetic overactivity is happening, because of which there is decreased peristalsis. Whenever there is decreased peristalsis, whatever the food is there, that will get accumulated in the colon, which will lead to distension. So distension, if food is there, food, otherwise air. So distension with air is happening. So clinical features ಏನಿರುತ್ತೆ, just like we said, colonic distension, so abdominal distension ಇರುತ್ತೆ. Along with that, since air is getting accumulated, abdominal discomfort will be there and sluggish bowel sounds because of reduced peristalsis. So how will we diagnose this? We will be diagnosing this by giving enema, which shows massive distension of the colon. Okay, basically distension ಹೆಂಗೆ ಕಾಣುತ್ತಂದ್ರೆ, there will be large bowel, entire thing will be black on X-ray, abdominal X-ray or on enema. This will be saying that there is accumulation of air and the bowel is distended, which is suggestive of colonic pseudo obstruction. Okay, so what is the treatment of choice andre sympathetic blocker kodbeku ನೀವು. So neostigmine, which will be blocking sympathetic overactivity. This, since it is a parasympathomimetic, it will act like a parasympathetic. So sympathetic overactivity there. Now we have two options. One, we have to reduce this sympathetic activity or increase this parasympathetic activity. So both will be balanced. So we are giving a drug such that this parasympathetic activity will also be increased now, and that will lead to balance between parasympathetic and sympathetic. So whenever we give neostigmine, most of the patients will be relieved within 3 to 10 minutes and they will pass massive amount of flatus because air was getting accumulated, and since they pass this, they will feel relieved. Okay, so what are the precautions we need to take before giving neostigmine is cardiovascular contradictions ಏನಾದರೂ ಇದ್ದರೆ ರೂಲ್ ಔಟ್ ಮಾಡಬೇಕು. ಅಕ್ಯೂಟ್ ಅಬ್ಸ್ಟ್ರಕ್ಷನ್ ಏನಾದರೂ ಇದ್ದರೆ ವಿ ಶುಡ್ ರೂಲ್ ಇಟ್ ಔಟ್, ಬಿಕಾಸ್ acute obstruction ಇದ್ದರೆ this will lead to increase in peristalsis, and on obstruction, if there is an obstruction and you increase it, it will not lead to relief in obstruction, it will lead to hyperperistalsis and again vomiting ಆಗಕ್ಕೆ ಶುರುವಾಗುತ್ತೆ. So we have to rule out obstruction, we have to rule out cardiovascular contraindications, and only then we have to give neostigmine. Okay, now coming to large bowel obstruction. So large bowel obstruction, most common cause, just like we had discussed yesterday, it was malignancy. For small bowel obstruction, it was adhesions. Okay, so most common site ellagutte large bowel alli andre rectum more than sigmoid colon. Okay, adhesions are rarely responsible for large bowel obstruction. Okay, what will be the clinical features in case of a large bowel obstruction andre colicky pain in the lower abdomen or in the hypogastric region. Okay, abdominal distension but not vomiting. So in small bowel obstruction usually vomiting will be there, but in case of large bowel obstruction it will be usually abdominal distension and absolute constipation or obstipation will be there, that is unable to pass both feces and flatus. Large bowel obstruction is a closed loop obstruction, That is, it is a real emergency and surgery should be done as soon as possible. Okay, why is this called closed loop andre? Once there is obstruction in this large bowel, once the food passes into large bowel, the food can't come back into small bowel because this ileocecal valve ಏನಿದೆ ಇಲಿಯಮ್ ಇಂದ ಸೀಕಮ್ಮಿಗೆ ಇಲ್ಲೊಂದು ವ್ಯಾಲ್ವ್ ಇರುತ್ತೆ, ದಟ್ ಈಸ್ ಯೂನಿಡೈರೆಕ್ಷನಲ್. ಸೊ ಯಾ, ಒಳಗಡೆ ಇಲ್ಲೆಲ್ಲ ಸ್ಮಾಲ್ ಇಂಟೆಸ್ಟೈನ್ ಇರುತ್ತೆ. ಓಕೆನಾ? So this is large intestine which starts from cecum and then ascending colon, transverse colon and descending colon. So the valve here, this valve is called as ileocecal valve. Okay, this ileocecal valve is unidirectional. ಅಂದರೆ ಫುಡ್ನ ಈ ರೀಜನಿಂದ ಈ ಕಡೆ ಹೋಗೋಕ್ಕೆ ಮಾತ್ರ ಅಲೋ ಮಾಡುತ್ತೆ. ಒನ್ಸ್ ದ ಫುಡ್ ಎಂಟರ್ಸ್ ಲಾರ್ಜ್ ಬವೆಲ್, ಇಟ್ ವೋಂಟ್ come back because of this unidirectional nature of ileocecal valve. Hence this is a closed loop. Once the food has entered here, it is struck, it should go this way itself, it can't come back. So because of this, it will go on distending as much as possible. After that it will burst off or other complications will happen. Hence once the food has entered here, once there is a large bowel obstruction, it is treated like an emergency. Before this bowel goes into necrosis and all, we should operate. Okay, so what is the treatment for right colonic malignancies adre? Just like we said, for large bowel obstruction most common cause is malignancy. Malignancy ಎಲ್ಲಿಂದ ಅರೈಸ್ ಆಗ್ತಿರುತ್ತೆ ಅದ್ರ ಮೇಲೆ ಡಿಪೆಂಡ್ ಆಗಿರುತ್ತೆ. ಸೊ ಇವಾಗ ರೈಟ್ ಕೊಲಾನಿಕ್ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ ಇದ್ದರೆ ರಿಸೆಕ್ಷನ್ ಆ್ಯಂಡ್ ಇಲಿಯೋ ಟ್ರಾನ್ಸ್ವರ್ಸ್ ಅನಾಸ್ಟಮೋಸಿಸ್. ಸೊ ಇವಾಗ ಸಪೋಸ್ ರೈಟ್ ಕೊಲಾನ್ ಅಂದರೆ ಎಲ್ಲಿ ಬರುತ್ತೆ, ದಿಸ್ ಥಿಂಗ್ ಅಸೆಂಡಿಂಗ್ ಕೊಲಾನ್, ಇಲ್ಲೆಲ್ಲೋ ಮ್ಯಾಲಿಗ್ನೆನ್ಸಿ ಇದೆ ಅಂತ ಅಂದ್ಕೊಳ್ಳಿ. ಸೊ ವಾಟ್ they'll do, they'll resect this part and whatever the ileum was remaining, they'll connect it to iliotransverse. That is called as iliotransverse anastomosis. So resection and iliotransverse anastomosis. If there is malignancy in the sigmoid, in this region, then they'll remove that sigmoidectomy, and then whatever the remaining is there, colon and sigmoid was joining colon and rectum. So colorectal anastomosis, sigmoidectomy and colorectal anastomosis in case of sigmoid malignancy. Or we can also go for total colectomy if it has started involving other part of the colon also, and directly connect ileum with rectum. Okay, this is performed under delayed presentation if whole colon is ischemic ashte. Okay, so next we can also treat it with a procedure called as Hartmann's procedure. What is Hartmann's procedure andre? It is a sigmoidectomy, descending colostomy and closure of rectal stump. Like rectum is closed and both sigmoid and descending colon is removed. ಈ ಪಾರ್ಟ್ ಪೂರ್ತಿ ತೆಗೆದುಬಿಟ್ಟು rectum ಇಲಿಯೋರೆಕ್ಟಲ್ ಅನಾಸ್ಟಮೋಸಿಸ್ ಮಾಡ್ತಾರೆ. ಓಕೆ, ಹಿಯರ್ ರೆಕ್ಟಲ್ ಸ್ಟಂಪ್ನ ಹಿಂಗೆ ಕ್ಲೋಸ್ ಮಾಡಿದ್ದಾರೆ. ದೇರ್ ಇಸ್ ನೋ ಏನಂತಾರೆ ಅನಾಸ್ಟಮೋಸಿಸ್ ಡನ್ ಇನ್ ಹಾರ್ಟ್ಮನ್ಸ್ ಪ್ರೊಸೀಜರ್. ಇಟ್ಸ್ ಬೇಸಿಕಲಿ ಲೈಕ್ ಆ ಕೊಲಾಸ್ಟಮಿ ಮಾಡಿಬಿಟ್ಟು ಬಿಡ್ತಾರೆ. ಅಂದರೆ ಎಲ್ಲಿ ಕೊಲಾನ್ ಎಲ್ಲಿವರೆಗೂ ಉಳಿಸಿದ್ದಾರೆ ಆ ಕೊಲಾನ್ನ ಡೈರೆಕ್ಟಾಗಿ ಓಪನ್ ಆಗೋ ಥರ ಆಚೆ ಕಡೆ ಅಬ್ಡಮೆನಿಂದ. ಓಕೆ, ಆ್ಯಂಡ್ ದೇ ವಿಲ್ ಗಿವ್ ಅ ಬ್ಯಾಗ್ ಆರ್ ಸಮಥಿಂಗ್ ಆ ಥರ.
Sir, can you repeat this once in English?
Yeah, Hartmann's procedure.
Sir.
Okay, so in Hartmann's procedure, basically it is a combination of different steps. Okay, previously what we were doing, wherever there was malignancy, we were just removing it off and we were joining whatever the parts were remaining. In Hartmann's procedure, what they'll do is they'll remove sigmoid. Okay, so here better I'll explain this. Yeah, in Hartmann's procedure, they'll remove descending colon. Okay, and they'll remove sigmoid colon. So what is below sigmoid colon is rectum, right? So now this is rectum, they are removing up till here, and usually what they used to do, they used to remove this and whatever the part were remaining they used to connect those parts. But now what they'll do, they'll remove descending sigmoid, descending colon and remove sigmoid. They'll just leave whatever the large intestine was remaining and they'll connect this to anterior abdominal wall, and whatever the rectum was remaining, that stump will be closed. So rectum is isolated now. whatever the food or whatever feces will be there, that will be passed through anterior abdominal wall, and they'll usually give a bag like structure where the feces will get connected here. So rectum is of no use now. Okay, so this procedure is called as Hartmann's procedure. So what are the components here? They'll remove sigmoid, they'll remove descending colon, and they'll just close whatever the rectal stump was remaining. Usually this will be done in case of elderly where there is sigmoid malignancy. Okay, if there is malignancy in the mid or lower part of the rectum, then defunctioning colostomy, that is followed by chemoradiation, and then tumor resection and colostomy closure will be done. That whatever I said alva, ಈ colon ತಗೊಂಬಂದು ಆಚೆ anterior abdominal stitching of colon to anterior abdominal wall, this procedure is called as colostomy. Stoma means opening, colon is opening in anterior abdominal wall. Okay, so this procedure is called as colostomy. Okay, now after dealing with this was about large bowel obstruction. Okay, most commonly causes malignancy, so related to those malignancies we'll treat it accordingly. After large bowel obstruction, next we are going to discuss about sigmoid volvulus. What is the most common site of volvulus in case of adults? Similar to intersusception, this will also be there. Okay, but in intersusception one segment was getting into another segment. Here something different happens. What is that? One segment will rotate on its own into other segment, just like gastric volvulus we had discussed. It will be rotating on its own, and this will lead to ischemia, and it can go for necrosis. Similarly, if the sigmoid colon rotates on itself and it leads to obstruction in the blood flow or anything, that is called as sigmoid volvulus. And sigmoid is the most common site of volvulus in case of large bowel. It can be anti-clockwise or clockwise. What are the mandatory factors in order to say that a volvulus has happened is there should be constipation, there should be long or narrow mesentery. Okay, why does this volvulus happen? Usually it happens in case of old age and in case of hospitalized patients. Okay, ಇದು ಯಾಕಾಗುತ್ತೆ ಅಂದರೆ ಯೂಶಲಿ ಓಲ್ಡ್ ಏಜಲ್ಲಿ ಕಾನ್ಸ್ಟಿಪೇಷನ್ ಇಸ್ ಮೋರ್ ಕಾಮನ್, ಆ್ಯಂಡ್ ಇನ್ ಹಾಸ್ಪಿಟಲೈಸ್ಡ್ ಪೇಷಂಟ್ಸ್ ಆಲ್ಸೋ ಬೆಡ್ ರಿಡನ್ ಆಗಿರ್ತಾರೆ, ಸೊ ಕಾನ್ಸ್ಟಿಪೇಷನ್ ಇಸ್ ಮೋರ್ ಕಾಮನ್. ಓಕೆ, ಸೊ ಅವಾಗ ಏನಾಗುತ್ತೆ, ಬಿಕಾಸ್ ಆಫ್ ಇನ್ಕ್ರೀಸ್ ಪ್ರೆಷರ್ there will be rotation of the sigmoid colon around itself. Also it will be more common in mentally ill patients and in patients who take opioids and antipsychotics. So it is a closed loop of obstruction similarly. Okay, and it has the signs of large bowel obstruction. Large bowel obstruction ಅಲ್ಲಿ ಏನು ಸೈನ್ಸ್ ಇತ್ತು? What are the signs in large bowel obstruction? That was colicky pain, abdominal distension, absolute constipation or obstipation. So what are the investigations we'll do? We'll go for X-ray first, and on X-ray we'll be able to see a coffee bean appearance. Coffee bean appearance ಹೆಂಗೆ ಕಾಣಿಸ್ತದೆ? Here coffee bean appearance, just like this. Okay, it is like one part of the sigmoid has rotated around itself, hence it is appearing like a coffee bean. Okay, so this, or it, you can also say it is a bent rubber tube, bent inner tube, whatever. So in tube ide we have bent it on its own similarly. Okay, so hence bent tune, or you can say omega sign. So like sigmoid colon has rotated around itself, so if you join these two it will be like a omega la. So it omega sign. So on X-ray you can say it is a coffee bean sign, or bent inner tube sign, or an omega sign in case of sigmoid volvulus. Or when we do barium enema, what will be there? There will be bird beak sign, or ace of spade sign, or bird of prey sign, basically like this. Okay, so what is the treatment now? We all know it is sigmoid colon rotating on itself, so we will have to derotate it or detorsion it. So colonoscopic, by doing colonoscopy wherever there is torsion we will detorsion it, and then we will have to go for elective sigmoid colectomy. If there is more than 72 hours, if the sigmoid volvulus has happened, there is most probable that it would have gone for necrosis. So hence that part of the sigmoid colon is removed. That procedure is called as sigmoid colectomy. If there is that is after 3 days it is removed. Okay, this was about sigmoid volvulus. Similarly, cecal volvulus can happen because ileum plus cecum plus ascending colon will be there here. Okay, so it is usually cecal volvulus is usually a misnomer because it should have been called cecocolic volvulus. Andre both cecum and colon will undergo volvulus. Okay, it has involvement of a part of ileum, part of cecum, and ascending colon because this was a junction, we have seen here. So here, this is a junction. This region will undergo volvulus. Hence, it is called as ileum, cecum, and ascending colon should be involved, and hence it should have been called as cecocolic volvulus. Okay, it is mainly clockwise, whereas uh, sigmoid volvulus could have been anti-clockwise or clockwise. Cecal volvulus is mainly clockwise, and cecum is relatively fixed. If free or mobile, there will be increased chances of torsion. Okay. So, what are the predisposing factors for cecal volvulus? Multipara patients who have more than two children, they are more prone for cecal volvulus because of a substance release called relaxin, which leads to relaxing the ligament of cecum, and that leads to cecum being free and mobile, which increases the chance of volvulus. Okay, and if there is any history of previous surgery, then these ligaments are divided, and hence cecum becomes free and mobile, which leads to volvulus. And malrotation, which in case this is a developmental anomaly during development or during embryological formation. If there is malrotation, then cecum, instead of being fixed, it would have been free, because of which again there will be increased chances of volvulus. And then distal obstructing lesion, that is proximal part of the colon distension leading to torsion. Okay. So, what will be the clinical features in case of cecal volvulus? It will have symptoms and signs of small bowel obstruction because twisting is at the level of ileum, and ileum is a part of small intestine. So, small bowel obstruction and symptoms ಕಾಣಿಸ್ತಿತ್ತು, that symptoms will be present in case of cecal volvulus. Though it is a part of large intestine, we'll see features of small intestine obstruction. Okay, so that is colicky abdominal pain and bilious vomiting. By vomiting itself, we can say it is a manifestation of small bowel obstruction, and then there will be absolute constipation. So how will we come to conclusion that it is a cecal volvulus? We'll go for abdominal x-ray. In abdominal x-ray, you will be seeing a kidney bean sign, like kidney ಹೆಂಗಿರುತ್ತೆ ಆ ಥರ ಕಾಣಿಸ್ತದೆ, kidney bean sign. Or you can also say comma shaped cecum. Okay, so what is the treatment here? What all is involving? We should remove that. Ileocolectomy, ileum and cecum or ileum and colon is involved, we'll remove that. And then whatever the part of the ileum is remaining, that will be directly anastomosed with transverse colon, that is iliotransverse anastomosis. So this was about cecal volvulus. Okay, now coming to last part, that is cecal bascule. Cecum folds in a cephalite direction anteriorly over the ascending colon, and this is called as cecal bascule. Clinical features there will be intermittent episodes of abdominal pain because of intermittent isolated cecal obstruction. This usually relieves spontaneously, no treatment is necessary. Basically this is like, so this is cecum and this is colon. So illenagutte, this will get fixed to anterior colon here. So whenever this is fixed, there will be abdominal pain. Okay, and it will relieve on its own. So sometimes it will get fixed and sometimes it will be relaxed. So whenever it gets fixed, there will be abdominal pain because of obstruction, and it will relieve spontaneously. Okay, so this brings us to the end of large bowel obstruction, overall intestinal obstruction.